This conference will now be recorded.
Okay, so Len and I are going to share this evening. Rick and Herb are celebrating the holiday, so we volunteered to take this on. The holiday being Jewish holiday, not necessarily Labor Day, but we're all celebrating Labor Day, I guess, here online. Okay, so let's. I'm happy to be back in Hawaii, at least for another 6-7 weeks before I go back to Minnesota. Flying with a mask on for 12 or 13 hours is not the most fun, but it's something we got to do these days, so it's okay. But I feel pretty good now. I didn't feel good last night when I got in. Now I'm okay.
Hadn't had enough oxygen for 12 hours.
Yeah, I think so.
Well, imagine the poor healthcare workers who are wearing those masks all day long, 5, 6, 7 days a week.
Oh, yeah. Yeah, that's going to be crazy.
And they're wearing the N95s, much more uncomfortable.
Right. Well, I had a KN95 on the plane.
Yeah, I've got one of those.
Okay, well, let's go ahead and start off with Larry Fish. Do you have anything? I see you're on tonight. Do you have anything tonight, Larry?
Nothing special, thanks, Peter. Len. It's Happy New Year, by the way. This is New Year's Eve for the Jewish holiday, Rosh Hashanah. Yeah, that's what the holiday is.
Right. That's why we gave Rick and Herb the night off. Okay, well, let's go ahead and where did you go? Let's go ahead and start with Dennis McGuire. He's got an interesting situation, and why don't you give us an idea what you're working with, because might be a little obscure to most of us, but give us an idea, so give us some background and let us know what your concerns are.
Sure. Hi, everyone. Happy Labor Day. So not great news tonight. My cancer's active again, despite the lutetium treatments. Last week, I went in for my 3-month check-in and had scans and PSA. The scans are showing some increased activity in the lymph node lesions, and not all of them, but some of the lesions. And my PSA from July until the end of August doubled. It went from the low 20s to 50. The only encouraging news out of that is that the PSMA PET scan is still showing that I'm PSMA avid, which means I'd be eligible for more lutetium treatments pending approval of the lutetium 177. So having said that, I guess there's a lot of unanswered questions in terms of, what happened with the trial, and what I do next. So the big question is, do I wait for lutetium approval, or do I look for another treatment in the meantime? So my doctors at Wisconsin Carbone think that the lutetium approval will be first quarter of next year, which they've kind of moved it out. Previously, they were hoping that it would be end of this year. So interested to hear if anyone has other intelligence on that in terms of when FDA may approve.
Is your trial over now?
Yeah, the trial's over. And just by way of background, the trial was 3 treatments of lutetium starting in March, ending in May. And this trial was slightly different than the original lutetium 177 trial, which is called the Vision trial. That one had, I think, on average 4 to 5 treatments and as much as 6 treatments for those trial participants. So that's effectively what Novartis went to the FDA with for approval, I believe, is for 6 treatments of lutetium.
Dennis, this is Dennis Correa. I have a couple of questions. Have you done the somatic gene sequencing to see if you have anything there that would make you more or less favorable to use lutetium? Did you go through that, or you just decided to try the trial?
I have done sequencing a couple times. The last one was 2 years ago, and there was really no mutations that were actionable at that point. But I am going to do additional sequencing. In fact, I have a biopsy next week.
Okay.
To do new sequencing. You know, it's been 2 years. I've had 2 treatments since then, so there could be some changes with the cancer.
Yeah, and I was going to suggest that if you hadn't done it recently, because I think they've made a lot of improvements in it. They get a lot more out of it now than just looking at mutations. They're able to look for susceptibility for different types of treatment based on the certain genes. So you've got that in the plan. That's good.
Hey, Dennis, it's Larry Fish. Sorry to hear that the PSA doubled so rapidly. Must be discouraging. Sounds discouraging. Do you have something, if you do something between now and the first quarter of next year, what might that be? And would that like make it harder for you to be in the lutetium trial to get an additional 2 to 3 sessions?
I don't believe any treatments I would do between now and another lutetium treatment. I don't think anything would disqualify me from lutetium, as far as I know. And in terms of what I'm going to do next, I don't know. My oncologist at Wisconsin wants me to pursue additional clinical trials. Obviously, his clinical trial, which is an immunotherapy, but it doesn't have a lot of history.
Did they discuss a bite trial?
Did not discuss a bite trial. They don't have a bite trial. One of the bite trials I looked at previously was an AMG trial, and I think I was disqualified because I had PSMA lutetium treatment. But there could be others. That's certainly something I might explore.
Is there another course of chemo you would consider?
Yeah, that's always on the table, either docetaxel or cabazitaxel.
Carboplatin, yeah. No
I'm,
one's suggesting that.
I'm kind of hesitant because I had a bad experience with my first round of docetaxel. My oncologist, well, two of my oncologists, their position is hold off on chemo until you have symptoms.
Yeah. Is there some way you can get like every 3 or 4 weeks PSA to just follow it really tightly?
Yeah, I'm going to do that. I think I'm going to go. That's a great point. I'm going to go probably every 3 weeks and get my PSA checked.
Yeah. Well, good luck. I hope it doesn't keep doubling. It's so discouraging when you sit there waiting for something to progress.
Yeah,
Can they
appreciate
can they
that.
do can they do any type of radiation on that? The tight beam radiation?
Yeah, I did have radiation 15 months ago in the pelvic area and the prostate gland. That was effective. I did SBRT 5 sessions, and those lymph nodes that were radiated have been quiet since. I think the challenge for me, and Peter probably has some insight here too. My challenge is the most active lymph nodes are in my retroperitoneum, if I pronounce that correctly. And
Right.
I think that's a tough spot to radiate.
Right.
Is that, Peter, is that what your oncologist or your radiologist has said?
Yeah, well, I had done so much radiation, I didn't do radiation there. I ended up treating that with chemotherapy.
Yeah.
And hopefully it did the trick. I know women, I mean, prostate cancer doesn't show up there a lot in guys. Women, cancer shows up a lot with uterine or ovarian cancer. It's common for women to have the peritoneal area. And some of them do a chemo flush where they actually put the liquid chemo into the peritoneal cavity and kind of flush around and drain it out. I asked my doc about that. He said, yeah, he wouldn't go that far with me. But I know that I read that that's one technique they use for women. Yeah, it's pretty freaky. Other than the fact that it wasn't working, were you tolerating the lutetium trial okay?
Yeah, I only had the week of the treatment, like a few days after, I just had fatigue and some dry mouth, but that quickly went away. And and this is one of the big questions that's unanswered is I responded to lutetium. So my PSA when I started treatment was at 100, and it went down to 22 after my second treatment. And the lesions also were reduced. So, potentially, if I go back on lutetium and stay on it longer, I could continue to have a response.
I'm
Yeah,
sure.
Dennis.
I'm sure you explored. I think Who is it? Al Latimer who's doing lutetium in L.A. someplace. So he must be on a trial there someplace.
Yeah, Dennis.
I'm not aware.
Dennis, this is Jake. I like Larry and everybody else. I'm sorry your PSA is going up, but I have a question. Your new Mets, they're all focused on the lymph glands, lymph nodes. Is that
Yeah,
correct?
yeah, my involvement is all in the lymph nodes.
And did the PSMA scan show that those particular lymph nodes are PSMA active?
They are.
They are.
So that's the only encouraging thing that I can report is that they're still PSMA active,
Right.
and they still should be sensitive to treatment.
The monkey wrench now is that they don't think it's going to be approved until next year.
Yeah, that's the challenge. And also, you know, my trial, I had 3 treatments, and the vision trial, those folks had 6 treatments. So that, you know, did that make the difference? Why
Might
those
very
folks potentially had a more durable response?
Are
Or
there
for that
additional
matter,
trials that you could try with lutetium?
no, I'm sorry, additional trials?
Yeah, additional trials with lutetium that you
Yeah,
might be able to get in on.
I think the only ones out there are now the managed access,
Right,
which are for folks that have not had lutetium yet.
right.
And that's a challenge with all clinical trials. You go on trial, if you respond to the drug and the trial's over, they take the drug away from you. So you do ask the question, should folks be allowed to stay on the drug after trial?
How long after you finished your final lutetium treatment did the PSA start going up?
2 months.
2 months. Yeah.
Do you have any thoughts on this?
Well, this is John Antonucci. I'm really sorry to hear those numbers. It must have really upset you very much. I don't know about cancer drugs, but I know that in studies in the past, if a unapproved drug seemed to have a life-saving effect, that oftentimes it could be continued on a humanitarian basis outside the strict boundaries of the study. I guess you've probably asked about this, but it sounds like you could make a pretty good argument that your PSA has gone up because you had an inadequate treatment course within the study, 3 sessions as opposed to 6 or something like that, and that you could similarly argue that you're probably still sensitive to the lutetium. And isn't there any way that they can continue you on a humanitarian basis right in the same center?
I did ask at Wisconsin where I was treated. They didn't think it was possible, but I don't accept that. And I am going to pursue speaking to Novartis, the trial sponsor, to see what can be done.
Yeah, I think that would be a good idea. I think they call that compassionate use. Is that the official terminology they use for that?
Yes, it is. And I'm glad that you're going to keep on asking.
I just had a question. When you look to a compassionate use drug, something that's off market for another, is lutetium 177 being used elsewhere? So you can say it's existing elsewhere, therefore it's around as an option? Or is it only with this advanced prostate
It's
cancer?
only with this, I believe.
So then you're asking for something that is not there and even off market. So I don't know what that means, but
Well,
Len,
no,
do
I
you have any
think
thoughts, Len?
I think just to clarify, I think lutetium 177 is active in the off market there are trials being done on a managed care basis. I think UCLA and Stanford, and I don't know what other institutions.
Yeah, that's definitely true, Dennis. You have to
So
pay.
it's a
Yeah,
possibility, and I just don't know. I think we're just in new territory, at least as far as I know.
yeah, Dennis, if I was you, I'd probably, continue pursuing getting it in some kind of compassionate use. It's probably not going to happen, but I would push it. But, even if you were to do docetaxel or cabazitaxel, if in fact you have a hard time with it, just tell them to give you half a dose instead of giving you 155 based on your weight or whatever the amount they give based on your weight. Tell them to try half a dose and see how you handle half a dose and do dexamethasone with it and just see for 30 days what happens and see if it holds your PSA or that's another possibility because I know
Yeah,
you've done it in the past and it hasn't gone well. So cut the dose in half or to 2/3. There's nothing states that you have to take the recommended
yeah,
dose based on your
yeah.
weight. So, I mean, I would try that. I did talk to Paul because I don't want to stay on docetaxel forever. I had my 22nd round last month, going for 23rd on the 17th. Um, and I don't want to stay on it forever. And I told Paul that when my PSA reaches 50, I really want to have something else in place. And he reiterated that, he thought lutetium would be available in the first quarter. So
Uh,
originally they were thinking third, fourth quarter of this year, but it doesn't look like that's going to happen. So and it is a drug, unfortunately, that he stated a year ago because they did clinical trials at MD Anderson. And his comment a year and a half ago was it was unremarkable, meaning that it does show or does effectively lower PSA and makes the cancer take a step back, but it's not long lasting. So it's not like it's gonna completely get rid of. Imagine there's some outliers where it in fact does
yeah,
will
yeah,
take a big step back, but for most guys, it buys them a year,
yeah. No,
6 cycles.
yeah, and I get that, Ken, and I knew that going into the trial. I just didn't think I was going to be only 2 months.
Yeah, everyone's different.
But again, maybe it's similar to what you're experiencing with docetaxel. Is you just have to stay on it, and stay on it as long as you can tolerate it, and you continue to get a response.
Right. No, I've thought recently about flying to Melbourne and getting it because you can pay for it there for $600. They've been doing it for 3 or 4 years.
Yeah,
So, but I don't know. I'd have to quarantine for 14 days, and quite honestly, I'm managing docetaxel fairly well with dexamethasone, so I'm gonna stick with it until the end of the year, but I understand your predicament where you need to make a choice. Either that or just let your PSA rise and then when it becomes available, but I don't know if I'd do that if a doubling time of 30 days.
yeah. I think, let's see, August 20th. Yeah, I probably will go in for another PSA um, next week, end of next week, and I think that'll be a big determining factor on what I do. If it stays on that doubling time, it's very concerning, but if it stabilizes a bit, then I've maybe got some additional room.
So what
Yeah,
treatment are you doing right now other than lutetium? Are you
Uh,
definitely on Lupron or Abby or something?
yeah, I'm on Lupron.
Right.
That's it.
Your
Hey,
T
Ken,
level?
Ken, if you don't mind me asking, when you went back on docetaxel, did you get an immediate response when
No,
you
actually,
re-challenged?
actually my response was The it was immediate. My local medical oncologist at the time said, "Hey, it's not working." I said, "No, it's working." My PSA was going up like maybe 30% per month. Wasn't doubling, but after one round of docetaxel, it only went up 1 point instead of going up 14 points. And I said, even though it didn't make it go back 100%, it slowed it significantly. So I said, I'm going to continue doing docetaxel until I know it doesn't work. And the second month, it cut it in half from like 49 to 25. And then the next month, it went to 16. So 3 months out, it was significantly lower. But, my dosage was, I think at that time, 155 or 160 milligrams. But quite honestly, I mean, we all handle this stuff differently, so I would say if you had a hard time on the full dose, take a third dose or half a dose and see what happens. But you might have to do it for a couple months. But I definitely noticed that it slowed progression.
That's good feedback. Appreciate it.
Yep.
Len, how about you? Do you have any thoughts on this?
Yeah, I was wondering, Dennis, do you know how many lymph nodes were lighting up?
I don't have an exact number, Len. I mean, I think it was several.
Because generally they don't like to use spot radiation if you have more than, let's say, 3 to 5 lymph nodes that need to be targeted.
Yeah, it's more than 5.
Yeah, so they probably wouldn't do that.
Well, hey, Lynn, I could say that Paul's comment was if there was some bad apples in the group, that it might make sense to zap 2 or 3 of them, even if there were more that were active, the ones that were the most active, at least for me. Because I said, hey, Paul, I know a lot of guys that have, because he's never been one that was, to say, hey, let's go zap these spots because I have multiple spots. So, but he recently said if there were a few bad apples that were more pronounced in the scan, that maybe we could go just zap those couple of spots. But it's not going to get rid of it. It's just going to slow it down a little bit.
Yeah,
I have my eye open on for those, and my biggest concern is making sure I don't get any sort of blockage from a lymph node or pain. If a lymph node starts hitting a nerve. And when I talk about blockage, when I was first diagnosed, I had some blockage in the pelvic area and did some damage to my kidney. So I've got to be very careful about my good kidney that I don't get blockage in that area.
The other thing, Dennis, is, we were talking about the continuation of the doses. That in a trial, that's more common if you're taking an oral medication. The fact that this is a radioactive substance with a short shelf life complicates things quite a bit for them to just say, oh, sure, let's get them back on lutetium. There are supply issues, who's going to be monitoring, who's going to be administering this. Now that the trial is wrapping up, the investigators are probably busy analyzing the data. I don't know if they have the bandwidth to continue administering the drug.
No, that for sure is a complication. It's an expensive process.
Yeah.
And I did learn that the trial I was on has been stopped. So they're not running the trial anymore because they're going to put all their resources behind the 617 that's with the FDA for approval. It's all Novartis, same company.
Oh, okay. Yeah. And you had R2?
I had R2, right, which was a slightly different ligand that delivered the lutetium.
So they're not even developing that anymore.
That's right. They stopped that trial.
No. The other thing I wanted to mention is Peter and I were talking about this earlier. I don't know how many guys are aware of Carl Foreman's experience with immunotherapy. I mean, these are potentially dangerous drugs. Don't go into an immunotherapy trial lightly, because he had quite a serious reaction. He was hospitalized for 5 days. And there really isn't good evidence that they're very effective for prostate cancer. So if it were me, I'd shy away from immunotherapy unless it was like a last option. And I don't think you're there yet.
Yeah, that's good advice, Len. In fact, I was aware of what happened with that other trial you just mentioned. And this immunotherapy that was presented to me does have Keytruda as a additional drug. So that does scare me.
Carl, I think Carl's not done with it yet, as far as I know. I spoke to him earlier this week, and he thought it might be curative for him in his situation, and discussed it with Dr. Tagawa that way. So, but yes, he really had a horrible experience, and I think he's feeling somewhat better, but I don't know what happened yet.
Well, Steve, did he have any PSA response?
I don't think he got to that. I really called him like Monday or Tuesday, and he got out of the hospital, I think, Sunday. And he, his platelet counts were down to some, 20 or something like that. He needed a couple of transfusions to get it back up. And he had this terrible rash, and, he really was very uncomfortable. And among other things, they didn't treat him very well at Cornell Weill. He was in 5 different rooms in 5 days and whatnot. So it was really a very difficult experience. But I know that he used the word. I mean, I don't use that word because I don't think that's a possibility. I came in late, so I didn't really hear the whole discussion. But, I'm looking to slow it down and, stay comfortable as long as I can. And he really is looking for a much more dramatic.
Yeah, I think anytime there's a promise of great
result, I don't know what the probability is, but I know they talked to him about the possibility this could do it. It's, I think it's called PSMA targeted alpha therapy, and it uses actinium and pembrolizumab and so forth, and one other. I think enzalutamide. He thinks that the problem was enzalutamide, but at the time I spoke to him, he wasn't sure.
No, that doesn't make any sense at all.
Yeah, I don't know. I'm just, at the time I said repeating, which also indicates that they haven't really communicated with him. And he's not he must have been really weak, because the few conversations I had with him, he's really well informed and really on top of everything. And the idea that he let them get away without communicating well enough that he knew what was going on, or he had the hope that he was going to know soon, was surprising to me.
I was going to make one other suggestion for Dennis before we move on. I know you say you have problems with the taxanes, docetaxel. What about an oral chemotherapy like cyclophospamide? They tried that with me, and I'm on it right now. It's not working for me, but apparently in limited studies, 30 to 40% do respond. And it's not a taxane, so it doesn't have the peripheral neuropathy and some of the side effects that you normally would expect from a taxane. It might be worth asking your doctor about it, Dennis. It's an older drug, but it is approved, and it is effective for some people.
What's it called again?
Cyclophospamide.
Cyclophosphamide.
I'll put it in the chat box.
Okay.
Yeah, I do remember that you were on it. Did you have any negative response to it, or?
No, I really, I mean, I've been tired for 10 years. So that's nothing new. And I am having some new pains now. So I don't think it's working for me, but 30 or 40%, it might be worth it for Dennis in particular. worth asking the question.
Yeah,
hurt.
thank you. Yeah, okay.
You're muted, Peter.
Frank Favish, let's move on to you for a while. What's your concern?
A quick update. I'm back for my next checkup on October the 5th with my doctor with blood draw and checkup. So I'll be getting that in about a month to see if my all of my readings are going to continue positive. I mentioned the last time I was accepted, and along with my wife as a caretaker, to the Orgovyx Ambassador program, and we're going through the process with the snow company about preparing for that. I continue to be on the Orgovyx without any major issues, except for ongoing hot flashes, which haven't changed, just have continued. But it looks like it could be a positive program. And the staff at Snow Company are very, very good professionals. And I found out that John Ivory is part of the program. And at this time, it's only a small group with John, myself, and one other person that they didn't name. And my wife, Gail, at this point, is the only caretaker on the program. So that's still, with anybody using Orgovyx, they're still looking for those who would volunteer to be a part of that ambassador program. That's my update.
What do you have to do?
One, you have to make contact with them, the snow company. Second thing, they have to, on a pretty lengthy phone call, you have to document your history and verify the fact that you're on Orgovyx. And then both companies have to look at that history and your background and then approve you as to be a part of the program. The next step that we're in the process right now, you have to develop a life story that will be your story that you're going to be presenting any place that you'll be talking about Orgovyx. And they have a group of writers that will work with you and make sure that you aren't violating any of the FDA requirements as you talk about it. And they want it in your words and what's gone on in your background and then with your history with Orgovyx. It sounds like a positive program, and one I think is, from my point of view, having had a very positive results from Firmagon, but not from the injection side, to be able to switch to Orgovyx and not have the 28-day injections and the painful injection site was a great benefit to me. But outside of that, it was more a physical improvement than it was on side effects or in terms of performance. But I didn't go backwards. All of my results continued to improve when I made the switch in March to Orgovyx. So I've been on it now for, I don't know, 4 months, going on 5 months. And I haven't had any adverse reaction. An example, when I started originally on ADT, I was on Lupron and had a terrible reaction, skin reaction to Lupron. And it took almost 5 months to be able to clear up my legs from what the Lupron injections did in terms of just a nasty rash. But I had no reaction like that from Firmagon except right at the injection site. And that tended to clear up after about 7 to 10 days, but still left a painful lump inside underneath my skin. In fact, I laugh with my wife. I called it a breakfast sausage that I had, and I stopped those treatments in February, and those 4 treatments, those 4 lumps are still there under my skin. I can feel them with my fingers. So it does have a major impact on you with the injections.
Yeah, that's for sure. A number of us can testify to that.
I have not had that experience. I've had 30 months of Firmagon injections, and once every 6 or 7 months, I have a little bit more pain, but I don't really get much of anything other than, a red spot and a little bit of pain for 24 to 48 hours.
Well, that's certainly good for you.
Yeah, we're all so different. I mean, but they wanted me early on to switch to Lupron, and I said, this one seems to be working. Why switch?
Mm-hmm.
Right. Yeah, we are all different. I was on Orgovyx for a month, and I was pulling my hair out. I mean, I had a terrible drug reaction to the Orgovyx and had to get off of it at day 29 or day 30. It didn't land me in the hospital, but it put me on heavy duty prednisone to clear it out. So we are all different. We have different sensitivities and reactions. As Len was saying, all these drugs can be powerful things. They're not just little. They're not just aspirins that we're playing around with. They're strong medicine, and we need to be sensitive to it. And
I think react quickly and not like hope. Like sometimes I wanted things to work so badly that I stayed too long.
Right.
Mm-hmm.
Firmagon has not been a problem for me. And
Frank, has your PSA been kept? I mean, has your testosterone level been kept as low on Orgovyx as it was on Firmagon?
Yes, so far. It did come up. It did come up a notch. I think from 8 to 15, but the PSA went down to undetectable and has stayed at undetectable. And my doc has said as long as the testosterone, he's satisfied. As long as I continue to be under 30 on the testosterone and my PSA is undetectable, he said that he's very satisfied with that.
Good for you. Okay, let us know. Let us get a flavor for your pitch when you get it all ironed out and what you're going to do and take it on the road. It'll be interesting to hear how you promote this drug.
Yeah, it's going to be an interesting process. We have to go through a 3-hour training program after we develop our life story, and then they said that then it would start to be promoted.
Frank, if somebody was on Lupron and abiraterone, would Orgovyx replace both of those, or would you still be on one of those?
I'm not really sure. As I said, I was on Firmagon, and I went to Orgovyx to replace the Firmagon, And right now, the other two drugs that I'm on, the other drug that I'm on is enzalutamide, and of course that had to be approved that it was okay to be on enzalutamide and still be on the Orgovyx and still be part of the Ambassador program. They had to sift through that before they approved me.
Gary, it would replace the Lupron. That's what it would be doing. So it's not the second line drug. Okay, let's keep moving on here. Let's Dennis Correa.
Yeah, I'm still here. I thought I would just take a couple of minutes and update you on my journey back into treatment after almost a year, I guess, on drug holiday. And it's frustrating because you can't make things happen fast enough. When your PSA is rising fairly quickly from used to be less than 0.1 when I started the holiday. But it's been difficult because I've got several parallel paths going at the same time. You know, I had to get a new biopsy from the prostate tumor to do the somatic work on and see if there's anything there that we can learn about which treatment would continue to work better rather than just going on what I was on before. So that's one path, and that took a little doing to get that done. And then at the same time, I'm working with other docs to look at radiation for both the prostate and initially with 2 bone mets, but I think we're going to probably drop that back to just 1 bone met. But it was interesting. I did have to go to the hospital for that for the biopsy, which I did just this past Thursday. And that was kind of a unique experience with the COVID stuff going on. That was number one, it was tough to get it scheduled. But before I could even do that, the hospital wanted me to get a COVID test. And it had to be by their own people. So then I had to schedule that first before I can even get scheduled for the biopsy. And then there's, you know, requirements for before you get the biopsy, you can't take this or that drug or, you know, this type of food or that type of food. And then I was going to be, you know, they put me under sedation, and so that was nice. I don't remember a thing about what happened, but he did tell me, I think he said he's probably 14 cores. And again, for several reasons, the radiation oncologist needed confirmation that the tumor on my prostate, in fact, was prostate cancer. And the only form of proof they would take would be a biopsy. And because I hadn't had one in the past 5 years, he needed a new one. So the biopsy served to hopefully to satisfy him. I don't know yet because I haven't got any feedback on the results of the biopsy, but I'm sure it will. He wouldn't even accept the UCLA PSMA PET CT that showed this tumor and had a high uptake. So I guess the PSMA PET CT at UCLA, it does have its benefits, but it doesn't serve all purposes. So that's where I'm at now. And then I'm on the on the radiation. I've got concerns about what did I do with my paper here? One of the areas that showed up, but it was labeled as indeterminate on the PSMA PET CT scan, was in my femur neck, and it was fairly low uptake. So I really don't see the benefit. I haven't really got to talk to the radiation oncologist about this, but I plan to bring that up because I know really for something that's small, you know, what's the risk benefit type thing here? Because typically, as far as I know, it's just for the only time you would radiate a bone is either there's a risk of a fracture there if this thing continued to grow, and it doesn't look like this one area has grown, and or pain, and that particular area is not giving me any pain. So why risk, you know, radiating it? And unless somebody else has got any information that would tell me that there's a reason to radiate it.
Dennis, have you done genetic testing, genomic testing yet?
Yeah, that's what the biopsy was also for, was for that. That's
Yeah.
going to Caris Industries. Caris,
that was my next question. Yeah, so that's an advantage of doing a biopsy. If you haven't done one in 5 years, you have tissue to send away.
That's why I mentioned that. Looking into it, they do very similar, I guess, to what Foundation Medicine does. And they're right here in Phoenix, so it's pretty close and easier to get it. And, you know, my primary doc, Dr. Singh, up at Mayo, suggested that as opposed to trying to do a liquid biopsy. He says, well, a fresh tumor tissue would be better, in his opinion. Look at all this stuff. So we'll be getting that back, and then we'll have another decision point to decide what we might want to do there.
Was there any other information from the biopsy that was surprising, or you haven't got the result yet?
No, haven't got any results yet, Peter.
Okay.
Because of the holiday. Anybody got a solution to post-nasal drip going down the back of my throat here? My wife just brought me in a glass of water. So,
Dennis, what was the test you took that the doctor didn't like, the PSMA test from UCLA? And where are you located?
I'm in Tucson.
Right. Okay.
Tucson, yeah. And the radiation oncologist here that I'm looking at using would not accept that. And I went over it with him, and he had the disc too with the images on it. So he downloaded that. He was very good when I met with him and took time, and he says, oh, you haven't seen the images yet, so let me show you the images. And we kind of looked at it together and took time to do that. So
yeah, I mean, I find that some doctors are comfortable with one test and other doctors are comfortable with other tests. But I'm interested in why he thinks something's superior to the PET scan.
Well, this is just to confirm, in fact, that it's a prostate adenocarcinoma and not something else. He didn't say what else it could have been, but it's on the prostate itself. That's the primary tumor, and I don't know what else it would be. But because I was going to do the biopsy anyway, we just had to take a few extra cores and split the tissue samples. But it's just.
Have any thoughts or questions for Dennis?
Did I ask him what?
Anybody else have any thoughts or questions for Dennis?
Well, just that we look forward to some news soon.
Yeah, it'll be interesting to see what the biopsy shows. And, you know, we've still got the plans on schedule for September to October for radiation of the prostate. So and then probably back onto the not the Lupron, but the replacement for Lupron. What's the name of that stuff? I can't remember.
Orgovyx?
No, not the oral, the injection.
Oh, the injection.
Firmagon.
No.
Eligard.
Eligard.
Okay.
Eligard.
Oh,
Yeah.
Okay,
I've
Gary,
done radiation before,
Gary
so.
Peters, you have something else you want to bring up?
Yeah, quickly. My oncologist does not believe in testing for testosterone. He says he doesn't need that to know how things are going. Am I on solid ground saying before the next appointment maybe you don't need it, but I need it. I want that test.
Yeah, I think you are. I mean, how else are you going to know if your ADT is working? There are occasionally some guys who their PSA can run up to 50 or more, even though they're on Lupron or Eligard or Firmagon or whatever. So I don't see, why
Yeah,
you
Gary.
can't add it.
Well, he tests for PSA, but he doesn't test
Yeah,
for
he
testosterone.
misspoken. He was saying T levels, testosterone up to 50. I'd say hell yes, you have the right to ask for T level check. You should ask for it every month. You're taking drugs to keep it low. I mean, the only way you know if it's low is if they check it. So yeah, tell the guy, give me a T level. Not, yeah, definitely without a question, I'd ask for it. I
How
mean,
often,
you're going
how often do you guys get T-level tests?
monthly, me. I take a
Well,
drug. I'm suffering through not having testosterone. I'm just 60 years old. Yeah, I want to know if that drug is working. If it's supposed to hold cancer at bay, you're damn right I want to know.
I've been doing it monthly for 6 years. I mean, such a cheap test. I mean, I don't know why this doctor would
well, I sometimes, when they don't want to give me the test, I go get it, because you can get them in most states from LabCorp or Quest without a prescription.
My on-call, this is John, my on-call just doesn't really care about it either, but when I asked for it, he just immediately said, sure, if you want it.
Okay.
He just says,
I
he just said, I know it's non-detectable or something. And it did in fact come back 3 when he got it, but he didn't really want it either.
Thanks, everyone. One other quick one. I'm wondering if anybody here who had their prostate removed had either a lymphocele or a hernia as a complication after their surgery.
I did. Ted here in Portland. I had an incisional hernia after my prostatectomy.
And I know of 2 young guys that had the same.
I did not. I had mine 3.5 years ago, and I had no problems afterwards, other than my cancer didn't go away. Minor problem.
I'm sorry, Ted, you said you had an incisional hernia, and
yes,
somebody said you knew 2 young guys. Did they also have hernias or lymphoceles?
They had hernias. Yeah.
Okay. Thank you.
Okay, Jeff Marchi.
Gary, I must
Oh,
say,
there.
young guys being 60.
Really?
That's young to me.
I know.
Young guy being 62.
And even in your 70s, testosterone's important. Probably 80s and 90s too. Jeff Marchi, go ahead.
Hello there. Well, about a week ago, my Embr device band broke. And I had been wondering for a while, well, it seems to help, but does it really? How much help is it giving me? Is it worth wearing? Because it's a pain in the neck. And even though the end of the band came out, I was able to push it in. And as long as I could then put it on, as long as I didn't flex my wrist, I could do the 10-minute hot flash run. And I was hoped it would do the job for me. Well, 2 days I lived with it like that. And I have a 6-inch fan next to my bed. And I had about 18 flashes in those 2 days, and I used the fan at least 10 or 11 times. On Monday, after those 2 days, I received the new band, the replacement band, put it on, and I think I've used the fan once in the week and almost a full week since then. the Embr device not only helps, but for me, it's essential. And the difference is that having to put the band on when I started to feel a hot flash delayed me starting it for at least 30, 40 seconds. And that amount of time caused it to just burn so hot that I couldn't, I needed the fan. But now that I've got a new band and I can hit it immediately, I had one while we had the meeting here, and I thought it was a big one coming on. I hit it immediately, it just went away. And so I am not just convinced. For me, it's essential. I just wanted to let other people know my reaction to using it.
Is this a common problem with the device, or where you have to?
Well, I only had it 2 months, but the thing is, I'm 6'4". I'm pretty big, and when my wrists flex, you have to put it on a little bit tight so it doesn't slide down. And my wrist flex, there's a lot, as big as I am, there's a lot of activity there. But I only had it for 2 months, so who would think it should break? Now, they sent me 2 bands to replace it. One of them is a plastic band, but it uses Velcro, which would not keep slipping like the magnetic one does. And I think it would hold better. But there's like an insert where the band sticks into, and it's tight enough so that it held it. But the thing, over time just gave up. But it only took 2 months.
And the company was responsive to send it to you pretty quick?
Oh yeah, I received it 3 days later. And actually 4 days later, but for a couple of days, it just started to break, and it didn't break completely for 2 more days. So I just went a couple of days without it being, where I had to put it together every time I used it, and it took at least a minute to put it on. And it made that big a difference in how hot the flashes got.
You didn't have to resort to duct tape, huh?
Well, the problem is, you can't cover the damn thing because it gets hot on the top. So if you cover the top, I thought about using rubber bands, but I didn't realize how important this thing was to keeping the flashes from getting bad. And boy, that sure convinced me quickly.
Anybody else have challenges with this thing, with it wearing out and breaking?
Also, Peter, does anybody know how this actually works? How does it prevent the hot flashes?
Well, Len actually had some, Herb had some technical information on how it works. But it's just that the cold against your skin seems to cause a psychological effect that it affects your whole body, even though you actually feel a cold running up your arm sometimes. And but Herb had a much more technical description. They actually have no technical description at all at the Embr website of how the physiology works.
And I'm assuming it's useful for women too.
Oh yeah, in fact, my daughter just ordered one because she gets hot flashes and wanted to stop them. No, the women is where they initially started the device for, and then they realized that men with prostate cancer have a major issue with hot flashes. So, I mean, it's a hot market. Pun intended.
Yeah.
If you want to know how it feels, take an ice cube and put it on the inside of your wrist.
Yeah.
It feels just like that when you turn it on when the hot flash starts and you activate it. It almost feels like something frozen against the inside of your wrist. And then it backs away, and then it does it in waves over the 10-minute cycle.
And the all-night cycle works pretty darn good. I've had almost no hot flashes at night anymore. We're using the all-night cycle.
Great. Well, amazing science.
Yeah. Here comes one now. Oh, jeez. My ears are getting hot. Ah.
Okay, well, thanks, Jeff.
All right.
Jerry Pelfrey, you're up.
Yes, sir.
I really don't have much. I just asked about the neuropathy on my toes. That just showed up about a month ago, and it's not debilitating in any way, but they just feel numb. So I was asking if there was anything you could do about it.
How many others of you have peripheral neuropathy, hands or feet? I've had it for the last year or so, since my chemo, the end of my chemo treatment. And I did go to an acupuncturist and got some pretty good relief that made a difference. I know acupuncture, a good acupuncturist, it's a little dicey right now with COVID, and I stopped because when COVID got kind of strange here in the islands. But I did get some relief and help, and mine's got to the point where it's just more of a nuisance. Another thing I do is one of those they have these wooden foot rollers that are grooved. They're about 12 inches long, and they've got two rubber grommets on the end, so that when they roll around the floor, you put your foot on them or feet on them, and it kind of massages your feet, and that's pretty good for getting some relief. Also, lying in bed and flexing your toes and your feet back and forth, get blood moving in there is helpful. For me, it kind of feels like I've got frostbite or something, a numbness in there that I can't get rid of and can't shake. Anybody else have any thoughts on this?
I have a question. Did you do the acupuncture while you were getting the therapy, chemotherapy?
No, it was after. The neuropathy for me didn't show up till the end of chemo, but Jerry didn't do chemo. I don't know what's driving his.
I have it too. I just started acupuncture on Sunday, so yesterday. I'm going back tomorrow for my second. I haven't felt any difference yet, but I know it takes a few times.
Okay. Do you have it? Rusty, where do you have it? In your feet or your hands?
My feet.
Your feet. Oh.
What are you on, Jerry?
Oh, I'm on Eligard with apalutamide and prednisone. I mean, the standard SOP,
Yeah, thanks.
Yeah, Jerry, I would think that the neuropathy is probably something caused not by Eligard. I'm not sure why you would have it. Usually it's a side effect of docetaxel or one of the taxane chemotherapies. For most prostate cancer guys, of course I have it. I've had 20 plus rounds of chemo plus 6 rounds early on, and I got it really on the 5th round almost 4 years ago. So I do gabapentin, of course. Gabapentin kind of numbs the nerve endings. Lynn could probably expand on how it actually works. But I also do a CBD THC salve, and quite honestly, it works pretty dang well. I don't know exactly how it works. I don't know how gabapentin works, but they both seem to work. So yeah, I can empathize with you in regards to neuropathy for sure, because every round it gets just a little bit worse.
Well, it's right. It's, like Peter said, the majority of it is after chemo. Why I got it, since I don't have chemo, I've never had chemo yet. Big question.
It'd be a good question for your GU Medon, like what the heck's going on here?
Yeah.
I know somebody who's got pretty bad diabetes and has the same problem. They take Cymbalta for it. There's doctors prescribed for eliminating the nerve, the loss of nerve feeling.
What was that?
Jerry, you can get peripheral neuropathy from hormonal drugs. Rick himself had it, still has it, even though he hasn't been on anything in, I don't know, maybe 10 years. I have a little bit of it. It's a little bit of a numbness. It sounds a lot like what you're talking about. Mostly if I'm in bed at night, I'll feel it. That's about the only time. Is that when you feel it?
Actually, I can feel it during the day, but it doesn't bother me.
There you go.
I can feel it right now, but
Yeah.
it's that, just like you, it's that
Yeah.
kind of a numb, not kind of a light numbness that's through the
Yeah.
toes.
Cymbalta
Yeah,
is the drug
does
he's
happen.
taking. Cymbalta for neuropathy. I'm not sure if it's appropriate for you, but that is somebody else who's got a very bad case.
And Jake is saying vitamin B6 is oncologist recommended. And also going back to the comment Jake made earlier, these new oral chemo drugs, if you ever have to go do chemo, seem to have a lower profile for things like neuropathy as a side effect, which is good. I mean, I really thought I beat it, and then all of a sudden at the end of my chemo, it just popped up, and I realized, and it doesn't go away very fast. You know, it lessens a little bit, but it can hang out for several years. You know, I had a buddy here who did a lot of chemo for colorectal cancer, and he was an avid guitar player. Unfortunately, he got it in his hands, and that was the end of playing guitar for him. He couldn't use his fingers for the guitar. So,
Wow.
it can raise havoc with us.
Yeah.
You know.
Well, anyway, that was all for me.
Yeah. Thanks, Jared. John A., you had something you want to bring up.
Yeah, I had a question. I don't know if Len is, are you still there, Len? This is a question for anybody on darolutamide. I got started on it about 2 weeks ago, and I want to sleep all the time. And I was wondering if anybody else got that, and if so, is it permanent or did it wear off after a while?
Well, Peter and I are both on it, and we have felt fatigue. Nothing like Zytiga, which I think we're also both on, right, Peter? You were on Zytiga also?
I was on for Zytiga for a year.
Yeah, so it's not as bad on darolutamide. Plus, darolutamide doesn't penetrate the blood-brain barrier, so even if you have fatigue, you're not going to have the mental fog that you would have on all the other second-line anti-androgens.
Yeah, I'd probably be in worse shape if I was on enzalutamide. I asked, because of the experience of the guys in the group, I asked the medical oncologist when he wanted to start me on enzalutamide if I could, you know, if he'd go to bat with me for darolutamide, even though I'm still hormone sensitive. And he said, yeah. And looks like I'm going to be okay getting it, but I'm tired.
I think you'll build up a
find over time.
I hope so. Yeah.
Yeah, I don't.
Now you're also on Lupron, right?
Yeah, Eligard, to be specific.
Eligard. So I mean, that's probably causing more fatigue than darolutamide.
Yeah. Yeah, it was kind of interesting when I was taking off abiraterone, no side effects went away. So everything I was experiencing was due to the Eligard.
Oh.
Yeah, well, I don't notice any heavy duty fatigue, or, you know, I haven't taken naps in several years.
Wow.
I just kind of got used to it, and it does fine with me.
Good. I had 2 naps today.
No, you want to make sure you get some exercise, you know, stay active for sure.
Yeah.
But I think you'll build up a tolerance to it and do fine, and it'll keep working. I mean, it'll do its job, but you've got to do your job and not give in to it.
Will do. I looked up the cost of these drugs when I was trying to get approval for it, and these are all about 12,000 a month.
Yeah, that's their actual cost. Yeah. I would
Yeah,
actually say, John, if you haven't talked to your doctor about doing only one of the drugs, I would. Because quite honestly, darolutamide, apalutamide, abiraterone, I think they're on a single drug therapy. I think they'll hold your T levels quite low. So you don't necessarily need to do both. And the question for the
yeah.
guys are, how many guys are doing just one? I'm doing just Abby and
I think
prednisone. No,
I think Len is only on darolutamide too, right? Or
I'm on darolutamide monotherapy, but it does
monotherapy.
not keep your T levels down. Zytiga will, abiraterone will, but not any of the androgen receptor blockers like enzalutamide, apalutamide, darolutamide. They'll allow your T levels to rise. Like mine's in the 300s.
oh,
But it'll keep your PSA down just as well.
When I was taking
Yeah. Oh, my
Zytiga,
PSA.
I'm sorry. When I was taking Zytiga,
My
I
PSA.
was also taking the Firmagon together, and then I stopped in October of 2020. And then, but
Yeah, well, I mentioned last week, I'm on darolutamide monotherapy last 3 weeks or so, not by prescription, but by choice because I had to get off Orgovyx.
Yeah.
And I think I mentioned last week that my PSA tripled in 2 weeks as soon as I went off the Orgovyx. So I'll let you know. I'll meet with my local oncologist here Wednesday, and then I'll meet with Dr. Schultz on the phone in a week or two later. They'll probably want me to go back on Lupron, is my guess, because the darolutamide doesn't seem to be keeping my PSA down.
Yeah.
As soon as I stopped the Orgovyx, it just shot up. So we'll see how it goes.
Ah, okay.
But we're all different. Every one of us is on a different ride.
no.
Like one giant amusement park with 30 different rides here, and we're just waving to each other sometimes from the top and the bottom.
Well said.
Stop the carousel. I want to get off.
Yeah. Ken, you've talked a little bit about what you're going through. Number 23 coming up. You got anything else you want to report in and give us an idea how you're tolerating it and doing? I mean, you're still going hiking and going on adventures and so forth, but how are you managing all that?
yeah, I can kind of give a little like quick thing. I mean, everyone knows where I'm at the moment. It is my maintenance plan for whatever the reason be, but honestly, I've been on it for 17 months. So I can say thank you, Paul. I would never have imagined doing docetaxel for so long. But your comment, keeping active, is so relative. It's just right on. I mean, it doesn't matter what you guys go through, you have to keep active. If you sit down and give in to it, you're giving in. You got to keep pushing because I must admit, I don't know if I'm a freak. I don't think I am, but I go on pretty long hikes even today. So, as far as, of course, I have neuropathy in my feet. I've added 4 milligrams of dexamethasone on days 3 and 4 to help with the chemo crash, and it helps about 80%. So on days 3 and 4, I'm up running around doing stuff, instead of sitting on the couch, which I was doing the first 12 months. I would take a round of chemo and I'd get 10 milligrams of dexamethasone, and then I'd have a crash on day 3 and day 4. Those 2 days I spent on the couch. And after about 12 months, I finally came to the conclusion, just give me bloody dexamethasone, 4 milligrams, just 2 tablets. you know, and I had to work hard to get my local medical oncologist because it's not standard of care to go ahead and give it to me. And I think Paul actually called from MD Anderson and pushed the guy and said, you know, just give him a prescription for dexamethasone for 2 days after chemo. And honestly, it's a big, for me personally, it was a big thing because it allows me to keep those 2 days in play. So my PSA has been going up slightly. You know, it went up 4 points 2 months ago, 2 points the last month. I'm still under 30. You know, if I can stay under 50 between now and the end of the year, I'm happy. Hopefully between now and when they get lutetium approved, quite honestly, I know lutetium isn't a long-term thing. It'll buy me a year. Maybe by then something else will be available. So side effects for me for chemo, honestly, were the crash. The crash was the killer. I hated spending 2 days on the couch. So other than that, my blood cell, my hemoglobin's like 13. My platelets are low, and if I rub my arm against something, I don't know if you guys know what a cherry is, but when you play baseball, you get them on your legs if you slide. And I have those on my arms. If I just rub against something, I get this big red rash,
We
but
call
it
them
doesn't hurt.
raspberries.
Yeah, so that's about it though. You
What
know,
happens after days 3 and 4?
I feel fine.
Really? Okay. Gosh.
Yeah, my white blood count doesn't drop. I think the drug is Neulasta. They were giving it to me every month for 12 months, and after about 14 rounds, I said, "You guys, why are you giving me this? It costs $2,800, and I don't need it. My white blood count is fine." And so they finally dropped that, and you know, I just basically go get chemo every 4 weeks and get my butt active, you know. So I go on a hike the day after chemo, and it's usually 5 to 13 miles. And then,
Wow.
you know, I keep pretty active. You know, I've had company in the Northwest because I'm in a small town I grew up in, and I've had company the last 4 weeks, and they've run me ragged. But quite honestly, it's been good for me. So I was telling myself this morning, watering the grass, I feel good. But I know everyone's different. I understand that not everyone can do 20 plus rounds of chemo. But for those that can, I strongly encourage you to consider it. You know, you can change the dosage. You can tell them, you know, I'm not doing so well on the normal dosage. Give me half. Give me dex. You know, you can tell these doctors what you want based on how you react. So, and everyone's different.
Why was
Anyone
it
have any
so hard
questions?
to get the steroids?
Say that again?
Why did they give you a hard time about getting steroids if you were in?
It's not standard of care. Pure and simple. That's it. It's not standard of care. Standard of care is 10 milligrams with the infusion. That's it.
Hey, Ken, does the DEXA, does that affect your sleep?
I must admit, I was taking it I took it at night one time, and yeah, it does. You know, if you take it in the morning, it doesn't. But if you take it right before bedtime, yeah, you're jacked. I would say don't take it at night.
You know, when I
It will
took,
also affect your appetite.
I don't know. I
At least
smoke pot, so my appetite's pretty high all the time anyway.
when I did chemo, they gave me dexamethasone. I didn't ask for it. I didn't know what it was. They gave it to me the day before, the day of the infusion, and the day after. And each time I cleaned the house thoroughly. So when I was done with the chemo, my wife said, "Can we keep you on the dexamethasone because the house is looking good?" That's a true story.
Ken,
That's
I had something similar, not a rash, but I would just scrape something or, accidentally just bump it. And I get a big red spot under the skin. And I complained to Dr. Singh, and he asked me how much prednisone I was taking, and I said 0.5. He said cut it in half and do 0.25. And I got to tell you, I haven't had that issue
Yeah.
by cutting my prednisone.
Yeah, I don't mind getting a rash as long as I don't have the chemo crash. So the rash that I get it doesn't hurt. It's low platelets. I know exactly what it is. It's just a low platelet count, but it doesn't cause any, it doesn't hurt. I mean, I must admit that if it breaks the skin, like I reached in and pruned a tree and I like took a 5-inch piece of skin off my lower arm, and it's taken forever to heal. But in general, normally it's just a bump and I get a strawberry looking thing and it doesn't hurt. So I don't give it any thought. I know it's low platelets. When I go off chemo, hopefully to lutetium, in January or February, if I don't go to Australia first, it won't be an issue then. So, yeah. But yeah, I think lowering the prednisone dosage would probably, I don't know, I think for me, the platelet is more of a chemo side effect than the prednisone or dexamethasone. So Lynn might have more on that than I know, but that's only my non-educated comment.
Yeah, the chemo will depress your platelet levels for sure, which is what's causing your easy bruising, Ken. But I was curious. Does Paul tell you that you are like an exceptional responder to docetaxel? Because I can't imagine there are many guys who can hike 5 to 13 miles while being on docetaxel for as long as you have been.
He said he's had 3. So I would say probably the answer is yes.
Yeah.
But I don't know. He said he's had 3. My local GU medic now, this Dr. Wong at MD Anderson Gilbert, he has had 2 that has had more than 20 rounds. So, I just signed up for 3 more, so I don't know.
Sure.
I'd say yeah, an exception.
Is
But it's
anybody
only,
trying to discourage you from that, or like it sounds like you're making all your treatment decisions? It's
I
great.
know, that's funny. It's funny you say that. Honestly, about 5 months ago, I've kind of taken it in you're right, I have been. I always run it by Paul first, but I've been pushing for kind of what I thought was right, and he's never objected. So it's not standard of care, but once you become fairly informed, you can make decisions because you know what your body's doing. You
Yeah,
know how you
I've been
feel.
doing it as well. Some doctors like it, some don't.
Right.
And I haven't always been right either, but
No, that's true. It's like
I've been
Lynn's
right
comment
more than
about
but not always.
immunotherapy is 100%. Those drugs they have great potential for possible gain, but they also have great potential for possible harm. So whenever you go on one of those clinical trials where there's great potential, you have to weigh the great potential for harm. The doctors
Right.
probably don't give it to you.
Yeah, very good, Ken. We're proud of you. You're amazing.
Yeah, it's inspiring. Thank you.
Level of activity has a lot to do with this, Ken. I'm convinced of it. I was very active when I was on it. I was active throughout all of it. I was on Lupron, Zytiga, and chemo at the same time. And if I didn't work out, all I wanted to do was sleep, and I only felt worse when I did. So to hear that you kept out that much hiking, it's commendable for sure. And I see a direct relationship. Can't be any doubt about it.
There's no doubt about it. If you sit down and do nothing, you're going to have fatigue and muscle loss, and it's just going to get worse.
Yeah.
So you have to push. When you feel bad, get up and get off your ass and go do something.
I found that out.
Yeah.
Even if you're a 10-year-old healthy kid, you got to get off your ass and do something.
Right.
You're a goner. So someone's been on the phone for the whole meeting. You want to identify yourself for?
Caller 01.
Yeah. Who is that? I don't know who it is.
Sounds like the audio's not working.
Okay.
That's why I had him muted originally.
Okay. Stephen, let's go to you. You probably have something to update us about.
Well, yeah. So last week was my first meeting, and I've more or less been on a holiday since the end of June of, well, that's not true. I'm taking pain medications and steroids, but I feel much, much better. And on Thursday, I have a meeting with the oncologist to discuss the next steps. And, you know, I've sort of made I've made an outline of the things that he has broached to me now. And actually, it's interesting that tonight has been very informative about that stuff. But the likelihood is I'm going to be starting chemotherapy sometime soon. And, you know, going back, the interesting thing is that I do feel good, and I have started working out. Yesterday, I did an hour on my elliptical machine, which is over my shoulder here. And I hadn't really done that since I started the Amgen 509 clinical trial. I sort of got worse and worse about being active. And then as my back got more painful, I stopped for months, which I probably haven't done since I was 12 years old. I haven't gone weeks without working out, let alone months. And, you know, I don't really know what he's going to say. And I'm going to try to let him do the talking and listen, because I've really been, I guess you guys call it the ABC Club, the Anything But Chemo Club, which I've been a charter member of since I started this thing, mostly because of my family history and watching my father do chemotherapy almost 40 years ago. And I don't really know what I'm going to do next, but it's sort of nice to feel as good as I do right now. And, you know, get back to feeling good. And the idea of going back to start doing things that are going to make me feel lousy again is, I try not to think about it for the time being. But one question, you guys talked about cabazitaxel last week, and it sounded like it was almost interchangeable with docetaxel, but maybe has a little bit less side effects. Did I understand that anywhere close to correctly? That, you know, I've never done chemo. I've done Zytiga and Firmagon for, I don't know, I guess I did it from May of 2019 till October of 2020. And then I started Amgen in December, and looking back on it, it never worked. And my PSA in June was up to, I think, 120. 121.7. And actually, I took it at Quest myself last week, and it's 71 now. So why it's going down when I'm not really treating the disease, I don't know. But plus, I don't, you know, it's a different lab, so I don't really know how accurate it is either. But I don't have that much to report now. I will have a lot to report and ask about next week. But like I said, it's nice to feel good. It's been a long time.
Who has experience with cabazitaxel versus docetaxel?
I don't have personal experience, but I know that it's a very similar drug, Stephen, to docetaxel. There was a study done to compare docetaxel and cabazitaxel, not for efficacy, but for patient preference. So the same patients were switched if they started taking docetaxel, after a period of time, they were switched to cabazitaxel or vice versa.
Right.
And it was, cabazitaxel was the winner, if that's the right word, as far as patient preference goes. There were fewer side effects, as you said. I believe that although docetaxel is approved for first-line use for prostate cancer, I think that cabazitaxel is approved for second-line use. So, you know, for what it's worth.
Yeah, I mean, he mentioned cabazitaxel and said he wasn't sure that he could get it approved.
Yeah.
So, but, you know, if it is worth fighting for, you know, maybe I should ask him to fight for it. I've had doctors fight for, you know, I think I got an oxygen scan when my PSA was 1.1, which they weren't supposed to do because the radiation oncologist at Penn fought for it and convinced them it was the right thing in my situation. And 3 years later, I mean, you know, they were getting ready to radiate my prostate bed and lymph nodes, and I don't have any involvement there, but I do have extensive metastatic lesions in my skeleton. And, you know, obviously my PSA is pretty high. So at any rate, you know, like I said, I got to make, well, I think I have to make a decision. I mean, I suppose that, you know, there's a possibility that my PSA could keep going down just by itself, I guess. I don't know. Does that happen? Like, how could it go from 120 to 70 from July 1st to August 31st?
Well, what are you taking now?
Just Firmagon once a month, every 28 days.
Okay, so that might be helping. And also, who knows, maybe that Amgen trial is having some latent effects in boosting your immune response.
Oh, okay. I was actually wondering if it was making it worse while I was taking it. But you're actually saying it could be the other way around. Now that I've stopped it for 2 months, maybe there's some immuno effect. That's interesting.
Yeah, I mean, I'm just speculating, but it certainly seems like a possibility. It is designed to boost your immune system. So maybe it just, in your case, it's doing so in a latent fashion.
I think, Lynn, I think that's pretty common for immunotherapy. It
Yeah.
doesn't give an immediate response, but it's like 3, 4, 5 months down the road. It's like taking
Provenge?
sickle cell C, Provenge.
Yeah.
They don't see a PSA decline immediately, but they say the long-term kind of effect or result of taking Provenge.
Okay, maybe that's why he really didn't want me to worry about anything but controlling the symptoms for a while.
It's not a bad idea. It's not a bad idea, especially if it's going down. But I'd also, if you haven't done docetaxel, I would probably, you know, consider it first and save cabazitaxel for later. So I know docetaxel is a little more difficult to handle, but just get off your butt and do some exercise after you get it. Don't sit
Well,
down.
I've been really good about that all my life till my back started to hurt from the immunotherapy.
Well, then you'll probably be fine.
You know, since I'm 67, since I'm 12 years old, I either was playing sports or basketball or working out since I was in junior high school.
Len
is correct. The docetaxel is the first line chemotherapy approved. Cabazitaxel generally is approved as a second line after a washout period. So, and as Ken has said, he's been on it for 20 some months and he doesn't have really any major side effects. I was on it weekly for about 23 weeks and I didn't really have any major side effects either. It just stopped working for me. So docetaxel.
I mean, that's interesting. Also, I've been told it's every 3 weeks.
Well, yeah, that's a standard, but because she was concerned about my other comorbidities, she decided to try me on a weekly basis, every 3 weeks, 1 week off. 3 weeks on, 1 week off. Because you get a lower dose each time.
I see.
Even
Okay.
if I could ask, why did you discontinue the Amgen trial?
My PSA was shooting up. While the lesions, the tumors weren't getting any bigger, they were getting more intense, and they were digging inside my vertebrae and my neck. And so I had radiation therapy, which seems to relieve most of the back pain that I have had. And, you know, I mean, even during that time, I would play golf and do things and try to push myself. But I didn't really do any kind of weightlifting and or aerobic exercise, which I really missed a lot.
Could I ask what the drug was with Amgen? Was it 160?
509. I don't really know what was inside of it, but it was the name of the trial was AMG 509. And I spoke to one other person that had a good I've spoken to two people. One I haven't spoken to in a while, but he had a great result. And the other guy actually had to come off of it because it stopped working for him also. And the cytokine effects with some of the higher doses. We were all in the dose escalation phase. And I wanted more because I thought it was close to working, but they wouldn't give me any more. I think they started to have some cytokine problems with some of the newer patients. But I'll see him on Thursday.
Okay, well, we'll report back in. And,
I will.
Yeah,
for sure.
Okay. So I'm going to finish up with Len. Len's got an interesting story about, some of the things our doctors aren't particularly looking after us with, but why it's important to just keep an eye on our reports, read things thoroughly, just stay on top of our not only our disease but everything else going on around us.
Yeah, I think we all probably have a tendency to think that, okay, so we all have our cross to bear. We have prostate cancer. We're not going to be affected by anything else, right? We've got prostate cancer. That's enough.
It's definitely
so anyway, I had even though my PSA is extremely low, my oncologist said, I want to do a CT scan just to make sure you don't have any non-PSA producing cancer cells. So we did that, and fortunately, it was negative with regard to the prostate cancer. There were no visible lesions. However, one of the things that the radiologist wrote under impressions at the end of the report was that I had interstitial lung disease. So, like, where did that come from? I had a CT scan done when I was first diagnosed. There was no report of interstitial lung disease at that time. I was a former smoker from about age 17 to 32, but that was like 40 years ago. So who knows? But as Peter and I were talking about fatigue after taking the darolutamide, but he didn't have shortness of breath, but I did. And I attributed that to the ADT drugs. Like, I've been on and off those drugs for 7.5 years since I've been diagnosed. So I thought maybe that was the issue. But I'm going to have to work this up I'm going to see my PCP tomorrow, see what he makes of this. Maybe he'll recommend I see a pulmonologist, but it could very well be that the shortness of breath that I've had is due to this interstitial lung disease. So keep an eye on everything that you read in your reports. Don't just look at the PSA and say, oh, I'm good, PSA is good. There might be other things going on.
Yeah, we got to pay attention to changes, symptoms, and all that stuff.
Yeah.
So, yeah.
I chart everything since I got diagnosed. And I would get my, they would only give me every 3 months, and I would go get a CMP and a CBC every month. And I keep track of it. And I guess somebody was talking about platelets. Don't you have to watch neutrophils and other things like that with respect to, some of these low numbers?
Yep.
What's the, I know this because my brother had brain cancer, the Neulasta, that he had dangerously low neutrophil. Oops. Did I just go off? No, I'm here.
No, we hear you.
At any rate, and I also watch alkaline phosphatase pretty closely in LDH. And what are they going to do for your interstitial lung disease, Len?
Yeah, well, I have no idea. It was the first I'd really even heard of this. And I did a little quick and dirty Google search, and it doesn't seem that there's really any treatment for it. And it seems like there could be varying degrees of severity.
Right.
So like I said, I'm going to see my primary care physician tomorrow, and maybe he'll refer me to a pulmonologist, and we'll see what they have to say. But right now, I have no idea what can be done, if anything.
It's not really even one disease.
Didn't you in years past complain about shortness of breath long before you ever started darolutamide?
Yeah, I did.
So maybe it's a regressive, slow acting thing that just kind of comes up on you that doesn't show up on scans.
Possibly. Well, John Antonucci, what did you say?
It's not really one disease, it's,
Yeah.
it really means that your lungs there's some scarring, maybe you could say, and it could be from lots of different things. Yeah, you'll probably get some pulmonary function tests where you blow in the tube and they tell how much restriction there is and all that. But it sounds like it's not progressive or anything.
Let's hope not. I don't really know. Yeah, I did have a cardiac workup about a year ago, and everything there was fine. But of course, none of those would be targeting or measuring your lung function.
Right.
So yeah, I'll probably be doing the test that you're describing, blowing through the tube. We'll see. I mean, maybe that's diagnostic. That doesn't mean they can treat it, right?
Right. But it sounds like it's mild. I guess we can get other things wrong with us besides prostate cancer, can't we?
I still get an annual physical, or try to remember to, with my personal care physician. I guess we all should do that, and probably we all do.
Yeah.
Right, but that doesn't necessarily mean that the PCP or any other doctor is thoroughly reading all the reports and impressions and so forth. I mean, these docs are pretty overwhelmed these days.
Yeah, I agree with that.
And we are not necessarily getting personal care. We are doctors are treating the disease and not the patient often. And that's the advantage of getting together like this, because we see each other as individuals, and we're not just dealing with one size fits all disease. It's going to work for everybody. We're individuals, and we're very unique individuals. So we're just staying on top of it. And don't ignore symptoms. And I don't know how many times I've learned that in the last 7 years, including when I was first diagnosed. You talk yourself out of something. Oh, this is nothing. Oh, I can work through this. This is just a nuisance thing. Nothing.
Most of us grew up in the walk it off generation. Football coach told you broke your leg. He'd say, walk it off. You'll be fine.
Right. Or my mother's advice, go to school and you'll feel better.
Right. There you go.
As long as you get out of my hair.
Yeah.
I guess. Very interesting.
Okay.
Well, Lynn, let us know what's up.
Oh, sure will. Yeah, next week I'll let you know.
Okay, as a wrap up, I just want to remind everybody that next weekend is the PCRI conference. It'll be online and you can register for it at pcri.org. They've got Dr. I'm spacing out here. Jonathan Epstein. Yes, what's his name from Mayo?
Dr. Kwan. Dr. Eugene Kwan.
Eugene Kwan. These people are pretty darn good, and it's worth plugging into. It's a free thing. Just register. It's is it Friday and Saturday or Saturday and Sunday? I think it's
Saturday and Sunday.
Saturday and Sunday. And
8:30 a.m. Pacific.
Yeah, always good for engaging stuff. And they don't just let doctors spiel off doctor speak stuff. They bring it down home and keep it honest and pointed. So you will enjoy it. And, for going to these conferences for years, number of years, the part I always enjoyed, which I don't think they do online, is they used to put about, at the end of it, they'd put about a panel of 6 or 7 docs together, and they'd have real cases. But they didn't show names or anything, but they'd show scans and talk about what was going on. And you realize that each of these doctors had a different approach in terms of treatment and what they would do and how they would deal with this person's prostate cancer. So early on, it made me realize that we are indeed individuals, and these doctors are kind of reaching for magic just like we are. They don't just necessarily have all the answers. So I'd encourage you to do that. Our next meeting is on the 14th, Tuesday the 14th, and remember it's 2 hours earlier. So it's 6 o'clock Eastern time, because I know a number of us don't get that straight. We kind of bounce back and forth on that. So we got to train ourselves to remember on Tuesday's meetings, they're always 2 hours earlier than the Monday meetings. So anybody else have any parting shots here?
Just good job, Peter.
And Len,
good job, Peter.
Okay.
Thank you, Peter. Thank you, Len.
Thank you all.
Thank you, Jay.
Bye, guys.
Thank you, Peter.
Thank you all.
Great job.
Thanks, everybody. Thanks.
Okay.
Bye.